obesity rates in the US, for example, they shot up dramatically after the 1970s, and they haven't really come back down. Now, I'm not going to blame seed oils or anything like that. That's not my argument. My argument really is that we used to have low time preference because our money worked, and it incentivized us to save and think long term. And one of the issues we have today is that we don't think long term. We think very short term. And that creates all sorts of negative consequences. You know, you're more likely to drink, you're more likely to smoke, you're more likely to eat unhealthily, you're more likely to gamble, you're more likely to have all sorts of disorders as a result of the fact that a lot of people are disillusioned with their own future.
We are live. Hello, man. How are you?
Great. Thanks for having me, Peter. Really good to be here.
Well, look, as you know, healthcare is a subject I'm really interested in. I'm fascinated in like the design of healthcare systems because obviously I live in the UK. British people historically love the NHS. It's something we're very proud of. It's absolutely fucked right now. I've obviously spent a bit of time in the US. I think their system's terrible. I spent a lot of time with libertarians who'd keep telling me that socialized healthcare is a disaster, but countries without socialized healthcare seem to be slightly less civilized, if you ask me, because you're in a situation where it's like people who can't afford to be looked after. So I'm just like, I don't know what the fucking answer is, man.
Well, I mean, I think I can fill in some of the blanks there.
You got the answer.
Not the answer, but maybe towards the answer. I've had similar experience to you in that I've worked and lived in multiple different systems. So I don't know if you know, but I'm a Geordie. I was born in Newcastle.
What?
Yeah.
No, you're not.
No, I am. I was born in Newcastle upon Tyne, but I only spent 6 months there of my life. But the reason I was born there is my dad was working there as a doctor, so I was born there for that reason. And then they moved to the UAE.
Are you black and white?
I'm Palestinian.
Fan? No.
Yeah. Yes, I was, especially in the Shearer days, but that was a long time ago, so haven't kept up. Now I'm a real Bedford fan, obviously, so I've had to switch teams. But yeah.
You're a Palestinian?
I am originally, yeah.
Okay.
So I grew up in Dubai, which has a kind of a more US-style health system, at least for the expats. And then my family moved to New Zealand, so I did med school and did all my training and stuff in New Zealand, which has a more NHS-like health system. And as part of my training, I ended up in Houston for a bit as well. So I worked in the US healthcare system for a year. And while I was there, I had this kind of jarring change between NHS-like healthcare and more capitalist free market type healthcare. And I got confronted by some of my preconceived notions, by some of my colleagues saying, why do you really think healthcare is a right? Like, why is it more of a right than, say, housing or food? You don't expect free food all the time. You don't expect free housing. Why do you expect free healthcare? From their mindset, that was just an NHS thing. The reality is, though, that healthcare is different than those things. And I know, we've both spent some time in Bitcoin circles with libertarians, and everyone talks in America about freedom of speech. Their NHS is freedom of speech. That's the topic that they think is sacred and cannot be touched. In the UK, healthcare is a similar topic. And the reality is that they're both quite important. So I often use this example with my more libertarian colleagues. If your 5-year-old son or daughter had leukemia and you had to sacrifice your freedom of speech to enable them access to healthcare, would you do it? And the answer is yes, they would do it. So does that mean access to healthcare is more important than freedom of speech? And often when you confront them with that, they kind of stand back a bit and they go, maybe healthcare is a bit more important than some of the other things that we think are socialized.
Well, cultural things and history is important. I had this debate with someone this week regarding guns in the US because I was like, First Amendment's free speech is super important, and the Second Amendment protects the First Amendment. Guns are important, and they're like, well, you're a gun nut? I was like, no. It's like, in the UK, I do not want guns at all. If there was a referendum on guns, it would get destroyed. I don't even think 1% of people would vote for guns.
Yeah.
We've culturally made that decision.
Yeah.
And it's pretty much a unilateral opinion. The US, it's a bit more contentious, but culturally and historically, they chose to have guns. We've chosen to have a national health service. If there was a vote to get rid of it, it wouldn't be a universal, but I still think most people would vote to keep it. But that's changing.
Yeah.
I just think sometimes this kind of imposition of the way we've chosen to structure our country should be how you should structure your country. It's bullshit.
Yeah. And there is, I think beyond that, there is a middle ground there, both in terms of healthcare systems and the gun issue and all sorts of issues. I think if you look around the world, there are plenty of examples of where a sort of a hybrid system where you leverage the benefits of both free market healthcare and socialized medicine actually gives you the best outcome. It's the most efficient outcome, and it gives you the best results. And so regardless of your, base cultural views in each individual society, if you look at things from a more dispassionate perspective, what will give you the most bang for buck? What will give you the best population outcomes for the money? And the answer to that question is reasonably clear if you compare different countries. We're lucky in this part of the world. We're in Australia. We're in Sydney right now. We have a hybrid system. So we don't have an American system and we don't have an NHS system. We have a 50-50 system, roughly. So 50% of the population in Australia is insured and 50% are not. The insurance schemes are partly government subsidized. So the government does have some measure of control. It's not a pure free market system. And as a result of that, when you look at the percentage of GDP that Australia spends on healthcare, it's lower than both the NHS and the US healthcare system. But when you look at outcomes, things like infant mortality, cancer mortality, just overall population age, what age do Australians die, we achieve better outcomes.
So better outcomes for less money.
For less money. Now, how does that work, and why does that work? And I think that's really the question that should be explored a bit more. And I have some thoughts on that. But
can we go back a step? Firstly, just let people know the area of medicine you work in, so people listening understand the kind of work you do. Yeah,
so I'm a surgeon. I basically these days only do bowel cancer surgery. So I'm very involved in advanced bowel cancer specifically, and I trained for many years in that. Part of the reason I went to Houston is I wanted to work in what would be regarded as one of the best cancer hospitals in the world, which is MD Anderson in Houston. So I went there for a year to get additional experience and come back to Australia with that. So I'm basically a bowel cancer surgeon, or more formally known as a colorectal surgeon.
And working as a surgeon, are you exposed to the entirety of how the healthcare system works? And is it something you and your colleagues discuss?
Yes, not really is the answer to that question. I am exposed to the weaknesses. So we've all noticed, and my colleagues and I often discuss how bed pressures are getting worse, waiting lists are getting worse. And that's a fairly pervasive problem across all specialties, including the sharp end of the stick, literally, which is cancer surgery. We still feel those pressures, and increasingly so. And I think that's the element we discuss. We do sometimes touch on comparing health systems, particularly Australia and New Zealand, because we're a shared college of surgeons. So most of our colleagues in New Zealand are part of the same fraternity that we are. And there are significant differences in the way healthcare is delivered in terms of funding. So that we talk about frequently.
Okay, so with the exposure to all the health systems you've seen, it's maybe an unfair question, but which do you think is a more broken system, the US system or the British system? Do you think it's worse as free market? Well, actually, I don't even believe it actually is free market, but that's another point.
Yeah.
As a purely capitalist system, or do you think it's worse as a purely socialized system?
So worse overall?
Yeah.
Like if I had to choose, I would choose the NHS, but that is because I tend to, as a medical person, I tend to want maximum benefit for maximum people.
Okay.
But where can you get the highest quality healthcare? That's the US. But for select people.
Yes.
That's the problem.
And so is it like anything which is capitalist, the richer you are, the better access to care you have? It's like if you're rich, you can go and eat a $500 steak compared to somebody who might go and grab a McDonald's, is it?
That's exactly right.
Yeah.
And it's a bit more complicated than that, obviously. In the US, there's actually a middle class that's probably more negatively affected than either end.
Wow.
Because there is a safety net for people who don't have the means, but have enough capacity to ask for help, which is another common problem in the US, where if you don't have the capacity to fill out a form, you're really left out in the dust. And I think that's a bit of a problem there. The middle class who don't get covered by Medicaid but can't afford high quality health insurance, they're the ones that you often hear horror stories about losing their house and going bankrupt, because there is no safety net for the middle class, the forgotten middle class that Bernie Sanders and others always talk about. So that's really the population that's most negatively affected by their sort of dual health system that they've got, where they've got Medicaid for the very poor and they've got really high quality healthcare for those that can afford it.
Okay.
Not in the middle.
Okay. And just on the US system, there's a lot of complaints about the price of drugs in America, which are considerably cheaper across the board in places like Canada and Mexico. Is that a problem of essentially corruption and price fixing? Or is it something else?
It's a problem where the incentives are not aligned between the free market and the good of the population. And that's a theme that you will see recurrent in this discussion, where if you leave something as fundamental as healthcare to pure free market dynamics, then you will have to sacrifice things like that. Because if you've got a really important drug that is very desirable, you can charge whatever you like. And this reminds me, actually, just as a slight segue. You once asked one of your guests a question, and it was related to a fiasco that happened in the cryptocurrency world. And you asked that person, who was a high-powered CEO, "Is what you did ethical?" Right?
Michael Sonnenschein.
That's right. And that really stuck out for me. I'll never forget that, because he was confused by that question, because that's not the world he deals in. People who are in finance and in, say, for example, a CEO of a drug company, they don't necessarily deal in that world. The world they deal in is profits, regulation, law. How much can I do that's legal, that's regulated, that I can get away with for the benefit of my shareholders, right? That is the pressure they face. They're not doctors. They're not nurses. There is no code that determines what you do beyond your obligations to your employer and to your shareholders, right? And so when the incentives are not aligned, bad stuff can happen.
Well, look, if you're a shareholder if you're a CEO of a large pharmaceutical company and your goal is to drive up the share price, you need to have either more expensive drugs, solve medical issues that need fixing, or hope people are getting sicker.
Well, yeah, so there are perverse incentives, essentially. And there are. And so, and you're talking about, mega corps with thousands of employees, right? And so is it unforeseeable that if the incentives are perverse that you wouldn't have issues like this? I mean, the reality is that's what happens. Now, I do draw the line a bit when some commentators will say, the entire medical profession is compromised. That is definitely not the case. There is advertising, and there is pressure from advertising and from companies that try and sway your view. But the difference between a shareholder or a CEO of a drug company versus a medical professional is we have a separate code of conduct that determines what we do. Something like the Hippocratic Oath, something like the societies and the colleges that police your activity and ensure that you are operating under ethical standards. And if you don't, there are consequences to that. So we're not immediately as exposed to some of the perversions that exist, but certainly we sometimes can be influenced by it. And I think that's where I kind of differ from some of the previous commentary that I've heard on some of the shows, which suggests that the entire system is corrupted down to the level of the medical professional. As a medical professional, I guess I'm biased, but I disagree with that statement.
I think it's potentially more with not surgeons, doctors.
Yes.
We call them GPs, obviously, in England, whereby in the US, they see salesmen. So salesmen will come and knock on their door and say, we've got these drugs that do these things, or we've got this version, and they try and incentivize or convince them to sell the drug. Yes. And there's some incentives in there with doctors to prescribe pills. And I think the general complaint is prescribing pills rather than alternatives like exercise, etc.
Yes.
Now, it feels like it's a problem that's worse in the US. There's a big debate in the UK at the moment where they're debating whether to prescribe Ozempic, which I don't know enough about. Probably could do it myself. But they're running an actual program up in, I think it's in Manchester. It might be Manchester, where I think they've got a 3,000 person test sample, and they're going to give them free gym memberships. And so they're actually starting to test alternative things. And so I see things like that happening in the UK, but within the US, I hear commentary that the health system's fucked and there's perverse incentives. But I don't see change because there seems to be too many people aligned to the benefits of the drug industry. And let me throw one more thing in there, because I saw one as I've always said this. When I get to the US, and the only time I watch TV in the US is sports. So the other morning I get up, it's early in the morning, and I'm watching Liverpool play. And obviously the halftime break, there's ads. And 1 in every 3 ads is a drug ad. And I regularly said this. There are adverts for drugs for conditions I didn't even know exist. And adverts for drugs I didn't even know exist and conditions I didn't even know exist. And then they have this fast-speaking set of warnings at the end, which is like, basically, if you take this, you might die or get cancer. And I'm just like, I think a purely free market medical system incentivize, it plays on the bad incentives of humans.
I completely agree with that. And so therefore, in countries that have generally more robust healthcare outcomes, direct-to-consumer marketing of drugs like this is prohibited by the government because you need an intermediary there between the drug company and the patient. You need somebody who has medical knowledge or scientific knowledge that can translate the ad that they're selling you to what is actually real and not real based on the available scientific evidence and based on your experience as a medical professional. If you allow drug companies to sell directly to patients, while that might be considered freedom of speech or freedom of capitalism in the case of the US, if it results in negative outcomes, then the society as a whole has to decide, is it worth it? It's similar with the gun argument. There is such a thing as freedom of speech, freedom of advertising, freedom of drug companies to do whatever they like, up to a point. When it starts to have negative societal consequences, then the society has to decide, is this what they really want? And again, I go back to this argument. There is a healthy balance between one extreme and the other. You can't not have a drug company in any way viable in your society because they serve a reasonable purpose. But at the same time, giving them free rein to do whatever they like is also probably not appropriate. So somewhere in between those two extremes is literally where the money is in terms of getting better outcomes for your population.
Yeah.
I think I see things as, balance is usually best when it comes to questions like this.
That's why I quite like, so we have NICE in the UK, the National Institute of Clinical Excellence. And look, it's challenging because they disapprove certain drugs, and then some people sue the government to make that drug available. Yeah, it might be just because they have to work to a budget.
Yes.
That's the thing. The NHS has to work to a budget. But I feel like that also creates a discipline. I also don't feel like doctors can you see if salesmen visit doctors in the UK? I don't know. Would you know this?
I'm not sure about the UK. There are very strict rules in Australia and New Zealand. So, salespeople can visit with permission of, say, the provider or the hospital, and there's very strict limitations what they can provide. And certainly they can't advertise their product directly.
Right.
So in hospitals in Australia, you will never see a drug company ad placed in a place where doctors can be influenced by it, with exceptions. Sometimes things get snuck in inadvertently, but that's not generally considered normal or the right thing to do.
Is there is there like a dual, how do I put this? Are there like two different sorts of medicine that this falls under? For example, Nurofen I can go and buy, and I'm pretty sure Nurofen advertise.
Yeah.
They're like over the counter.
Yeah.
So are they just classified differently? With over the counter, you're allowed to advertise. What is the kind of medical? What makes something over the counter?
Yeah. What makes it? The individual country decides. But in general, there are rules on what is a prescription medication and what is an over-the-counter medication, and that changes with time. So very recently, for example, where I live, they've reclassified drugs for urinary tract infections as being able to be dispensed by a pharmacist.
Okay.
And the reason for that, despite the fact that generally it was prior to recently, it had to be prescribed by a doctor, is it was a high burden on the GP system where patients would come in for very simple UTIs, and that would take up a GP slot unnecessarily. So the government decided fairly sensibly to we should probably shift some of this burden away from the GP so they can see more high intensity presentations.
Can you bring that back up? Cheers, Danny.
One thing I will say, we don't want to crap on the US system too much. One thing about the US system that I do like when it comes to advertising is any payment that's made by any drug company or device manufacturer to a doctor is declared on something called the Open Payments Database. Okay. And the reason I want to mention that is any person can go on the Open Payments Database, search the name of their doctor, and it will tell them exactly how much money they got paid by who.
I bet they don't. But people don't do that though.
Well, it's pretty shocking when you read it, but we don't have that here. So
it's shocking seeing the payments they're receiving.
Yeah, sometimes it's astronomically high, and sometimes it's for research things, but at other times it's just like a direct honorarium kind of payment.
Okay, so here,
but
UK,
at least it's publicly declarable there.
Okay, for the people listening, UK to offer weight loss jabs to unemployed with weight issues in economy boost. Yeah, so this is an interesting bit. So prescribing weight loss jabs to obese unemployed in the UK could unleash economic potential of the fat man in Europe, the health minister believes. In the world first, UK Health Secretary Wes Streeting has unveiled plans to give weight loss jabs to unemployed people who are diagnosed as being obese. So that's an interesting one because the part of the debate is should the Department for Work and Pensions be involved in healthcare.
I would say that's a categorical no.
Yeah, but this is where it is.
No, I understand.
The DWP are essentially the ones driving this because they want to reduce the burden of people who can't work.
Yeah.
I just flip it. The only way I would flip it is offer people a countdown on their
Based on their
welfare
performance.
and a membership to the gym.
Yeah. I mean, more importantly, maybe we should work out why the obesity rate suddenly shot up in the early 1970s when it was fine for decades before that. I think that's a bigger question. Why are people so obese? Like, what is the reason for that? Is it reversible?
Tell me. I'm actually classed as obese.
Well, I think it is reversible.
Okay.
I think, I'm not sure. I realize we're trying to be a bit more broad in our discussions here, but in the early 1970s, something changed.
Yeah.
And if you go to their website that we all know and love, WTF
What the fuck happened? Yeah.
Yeah. If you look at obesity rates in the US, for example, they shot up dramatically after the 1970s and they haven't really come back down. They've sort of stabilized, but they haven't come back down. And I guess the question is, why is that? Is it the low time preference, high time preference thing? Is it something to do with, let's sell as much high calorie, cheap foods as possible? And are we sort of incentivized to consume that above everything else? It's probably something to do with that. And given it's such a recent phenomenon, I'm sure it is reversible if we think about it a bit harder.
Well, look, tell people what the fuck happened in 1971, because there's going to be people listening to this who haven't listened to the 860 other shows we made about Bitcoin.
Yeah. So I guess my interest here, and the reason I got introduced to you guys really, is what is it about our healthcare funding that's driving all these negative consequences? So one of the things about obesity is that, you can see that there. Now, prior to the 1970s, the obesity rate was always roughly between 10 and 15%.
I mean, but it's tighter than that. It's like from 1960 to 1980, so over a 20-year period, it's that looks to me between about 13 and 15. That's 2 percentage points difference.
Yes.
And then from 80 to 94, we've shot up to 24%, 23.5%?
Yeah, unfortunately, even though 2017, 2018 got above 40%, we're sitting at about that now. So it's sort of plateaued at that level.
At which point, percent?
So at about just above 40%.
Well, yeah.
So,
but,
like today, I'm saying.
Yeah. But that is from essentially 13% in 1960 to 43, 44%. Severely, they've changed. We call it morbidly obese.
That's right. Well, this is just obesity. So this would be above 30.
Yeah, and so severely obese was what do you reckon that is? 1%, under 1% in 1960. So essentially, the severely obese has nearly reached the rate of what the obese were.
Correct.
Okay.
Now, I'm not going to blame seed oils or anything like that. That's not my argument. Mm-hmm. My argument really is that we used to have low time preference because our money worked and it incentivized us to save and think long term. And one of the issues we have today is that we don't think long term. We think very short term. Mm-hmm. And that creates all sorts of negative consequences. You're more likely to drink, you're more likely to smoke, you're more likely to eat unhealthily, you're more likely to gamble. You're more likely to have all sorts of disorders as a result of the fact that a lot of people are disillusioned with their own future. You don't know what you're going to, when you're 20, you don't really know what your life's going to be like when you're 40 and 50. That's a relatively new thing. I don't think it was the same in our parents' generation. They, despite the fact they might have had a harder life, they had a bit more trust in the fact that their future was secure than we do today. And I wonder whether that sort of societal consequence results in weird spin-off side effects like this, where we eat unhealthily and we get fat.
I mean, look, it's a tricky one because I don't want to put it all to come off a sound money standard, but I think there's this kind of, we went through a period of industrialization, and then I think we've gone through a period of crazy capitalism.
Yes.
Where we've seen companies have the ability to understand a lot more about data and people and what works, what doesn't work, the science. They understand if they put certain ingredients into certain foods, it gets us hooked. They know if they put salt, we need a drink. They've just got us hooked on shit food, and then it's available everywhere. You can go to McDonald's and get a meal cheaper than you can buy vegetables at a supermarket. Plus, it tastes nicer, right. And there's a McDonald's in every fucking corner. Yeah. I think that we've just had this whole societal shift where everything is easy and available for all of us.
Yes.
And that's happened at the same time where people have to work more. What one salary used to buy, two now buy.
That's right. Both parents to cook at home.
Yeah. I mean, look, I'm a single dad, and after a day's work, being motivated and able to cook a good meal for both my kids was hard. I've tried it. There's plenty of times where we've ordered, like, takeaway when I was a kid was rare. It was
a treat.
Yeah, like once a month. We could have done it twice a week sometimes, or we go to the pub and get that feels slightly better. It's a cooked meal. But it's this like cultural shift whereby everything's just been made too fucking easy.
I agree with that. Well, except for the working environment, that's been, which you pointed out. So both parents generally have to work just to make ends meet. And access to high calorie foods is very easy. And that's also a recipe for what the graph that you're seeing here. But I have to say, I don't think that necessarily was the case in the 70s and the 80s. So it's been a gradual change, but it takes time for obesity to find its way into this chart. Like this is a lifetime worth of effect. It's not like you wake up at 5 and you're obese. Generally speaking, there's a bit of a lag period.
So we've not peaked.
Well, we may have peaked around now, I would say, because it seems like the figures are not getting a lot worse, which is a good thing. And it gives us hope for the future. And I don't think that's the effect of Ozempic or bariatric surgery, which is weight loss surgery. I think that's the effect of it doesn't get much worse than this. It's pretty hard to have over 40% of your population obese. So hopefully most of us are thinking that we can reverse some of these trends with time. And I think, like it or not, I think sound money is part of the solution, if not a big part of the solution.
The humble bee, a keystone species crucial to the survival of Earth's inhabitants. Here's how things would look if bees vanished. And here's how they'd look if humans vanished. But imagine if instead we became a keystone species by doing things the right way, by taking responsibility for our actions and becoming the solution. Iron mines the world's most responsible currency the right way. Because the future depends on it.
Yeah, it's funny, but the reason I think sound money is part of the solution isn't because I think the system has become just corrupted by money, and suddenly if we have sound money, these companies won't exist. I think sound money is in a window into a world that we've ignored, into a world of discipline,
long-term
thinking, morality.
Yes.
I mean, let's be honest. There's some of the shit that goes into these pesticides and herbicides. Yeah. It's not good.
I mean, can we talk a bit about healthcare funding in general and how that relates to that? Yeah. So one of the things I mentioned in the Bitcoin Alive talk and that I opened my eyes a bit was the way healthcare funding, it has nothing to do with healthcare price. So the way we determine healthcare funding has nothing to do with healthcare price, and I'll qualify that. So I don't know if you remember, but you had Preston Pish on here. Yeah, He showed this chart of the American Bureau of Labor Statistics or something, and it showed the prices of goods and services with time and the different inflation rates of the different goods and services. Mm-hmm. And at the time, you guys focused on the difference between CPI and house prices. I don't know if you can bring that chart up, but you sort of glossed over what the highest ticket item on that chart was. Which was hospital services. So there's this graph which shows inflation and cost of things. CPI is somewhere in the middle because it's a blended average of everything. Cars and things are down the bottom. Food is a little bit higher. Yeah, that's right. That chart. And then you've got housing, which is pretty up there because housing is a scarce asset, I guess. Yeah. But the number one item, the one that went in price the fastest since 1971, is hospital services. Now,
what does that mean when you say hospital service? Is that surgery?
Healthcare. Yeah, just hospital beds and just going to hospital for whatever treatment that you need.
Okay.
And it includes medication costs and everything else that you get in a hospital.
Yeah.
So, and the question is, why is that? Why is the inflation in price of hospital services? I think there's one with the Preston Pish one with the multiple graphs. I don't know if you got that one.
It's the one where it's kind of like the red lines are at the top and the blue lines at the bottom. If you
I've actually got it on my laptop.
If you go on to ask ChatGPT.
Effectively, it goes up. Healthcare costs around the world, particularly in the developed world, they go up in price about 10% a year.
Okay.
So it's one of the fastest inflating prices of anything, any good or service. Okay, and in Preston's chart that he showed, it is the fastest growing. That's the one there. So that's until 2017.
So just so for people to listen, let me explain to them. So this is price changes, Jan 1997 to December 2017, showing like price inflation. So down the bottom is TVs, which become much more affordable. Toys, more affordable. Software. So it's a bit like people understanding when you go and buy a TV now. The TV that you buy now for 5,000, in like 5 years you'll get it for 1,000. And and cars are about in the middle. And then things that have gone up in price is food and beverage, housing, wages, medical care services, childcare, college tuition, college textbooks, and hospital service. What's the difference between medical care services and hospital services?
So one is inpatient hospital, and one's outpatient stuff.
Okay.
Yeah. So or GPs and things like that.
So overall inflation's at 55.6%. Medical care services looks like it's about 120%. Hospital services like 220%.
Hospital services are 220%.
Yeah.
Yeah. And this is till 2017. There's one that goes till 2024, and that spikes even faster towards the end because of COVID and other things.
Holy shit. Okay.
Yeah. So it's gotten worse since then. Now, the issue with that is, how do we determine increased healthcare expenditure? And that's constant. NHS, the US, Australia, New Zealand.
But this isn't increase in total spend. This is the cost. Of the service itself.
Correct.
Like for like.
Price.
Yeah.
Yeah. Whereas what we spend on healthcare goes up about 2 to 3% a year. So the NHS funding goes up 2 to 3% a year. Australian healthcare funding, the amount of money the government budgets per year, in addition to the last year, is 2 to 3%.
So this is why we got bigger waiting lists.
Correct. Because the funding is not in any way keeping up with the price. So if you spend 2 to 3% a year extra on healthcare, but the price has gone up 10 to 20% a year, you can expect worse outcomes. Right? Now, if you look at the number of hospital beds just as one measurement, number of hospital beds per capita across any country, let's take Australia, for example, it's a straight line down. The number of hospital beds per head of population is a straight line down since the 1970s.
Is it total and proportionate down? Total bed numbers down?
Total bed numbers are going up very slowly.
But not at the
populations
rate.
Yeah, that's right. So,
okay.
and it's because the cost of a hospital bed is high and it's increasing rapidly. And so the additional funding we're getting, government funding and other sources, has no hope of keeping up with that. And so you'll get less beds for your dollar with every passing year, if that makes sense.
But why has there been so much? Why is this
That's a good question. So
here we go. Sorry, just Danny's bringing up number of hospital beds per 1,000 inhabitants. China looks like the only one that's gone up.
Yeah.
But it's in the, what's that purple one? Germany. Yeah, everything's kind of gone down. Do you know what's weird? It's like the China chart is almost inverse to the rest of the westernized countries.
Yeah,
Sweden,
well, different pressures. Now, the other thing to mention here is it's not just the number of population. The population is older and sicker in 2018 than it was in the 1960s.
So there's more demand.
That's right. So each individual we need more beds anyway, even if the population stayed constant, right? So what you're getting is less beds per capita. You're getting less drugs for your dollar. You're getting less operations for your dollar. Now, what that translates to is longer elective surgical waiting times. In Australia, we have a real problem with hospital ramping. So this is where the ambulance literally can't deliver the patient, so they just queue outside the hospital.
Yeah, we have that in the UK.
Yeah, so all these things are all worsening with time because of the fundamental fact that healthcare inflation is running at 10 to 20% per year, but healthcare funding is running at 2 to 3% per year. Now, why is healthcare inflation running at 10 to 20% per year?
Yeah,
that was the question you asked.
That's the big question.
Well, it's a scarcer asset than housing. It's a harder money than housing, if you want to look at it that way. So I'll qualify that. It is easier to build a house than it is to build a small hospital. And it is easier to add apartment beds than it is to add hospital beds, because hospital beds are harder to make more of. Because a hospital bed is a fairly high-tech bed. So a hospital bed requires oxygen delivery, it requires expensive monitoring equipment, and it requires staff. You have to pay a nurse's salary to staff a hospital bed. It's not just a box like an apartment bed would be. And so because it's harder to make, in other words, a scarcer asset, a scarcer resource, the price goes up faster. It's really that simple.
But there's such a range of costs that go into hospital services, right? It's
correct.
It's people.
I'm just using beds as an example.
Yeah, but I'm just thinking it's people, it's infrastructure, it's because there was a chart I once saw that showed the change in the number of middle management staff for a hospital versus the number of new clinicians.
Yes.
And there was, see if you can find that one. And the clinician growth was minimal. But there was a huge growth in back office staff.
Yeah, so that is a response to not understanding what the problem is. So, when the reason the managerial class in hospitals grew so quickly is because they're trying to fix this problem, but they're not really doing it. They don't understand the source of the problem.
Yeah.
So they just go, why is ramping bad? Well, how come the hospital beds are not keeping up? We've got more beds this year than last year. It must be a management problem. Let's get more managers in to sort this out, to try and get more for less. That was the idea behind what they call managed care. So at a certain time, mainly in the 90s and early 2000s, there was this flip from let's hire more frontline staff to let's hire more administrative staff to try and sort out the problem. And the issue with that is that, having a manager is all well and good, but having 20 managers doing the job of one doesn't fix the problem.
Hospital hires by 2023 hospitals employees hired by job category: nursing 13,000, administrative 8,600, clinical assistants.
Which countries? Is
this wasn't the chart that I was thinking of, Danny.
No, there's a graph that shows the growth of admin versus frontline staff. We've all noticed that, in our daily lives, that there's almost some hospitals have an entire separate building that is just administrative, separate to the hospital.
Could administrative be a lot smaller? Is it
no question?
Yeah. Okay. So where are they wasting? Where's the waste in administrative?
Well, it's the same as any kind of big. This is mainly in government funded institutions. Usually, private healthcare systems have way less admin to frontline staff because they run like a business.
Yeah.
The problem with any sort of large government institution is there is this inherent bloat with time.
Bureaucratic.
That's correct, and so that's generally what happens. So and they get busy with various activities. But
This chart's insane. So anyone listening, we've got a healthcare administrators far outpays physicians in growth chart.
And look at where it starts.
That's hilarious. It starts in 1975, and they look both about the same. Whereas, it's like marginally above the line. Let's say that's 50%. Right. So from 1975 to 2010, physician growth is what? Was a percent? 100% growth?
Maybe that, yeah.
Okay, and then admin growth has from 1975 to 2010 about 3,250%.
This is probably a US chart. And so you would find probably that physician growth isn't really keeping up with population growth necessarily from 1975.
True, yeah.
And so that is a more natural chart. It's the purple one that's completely unnatural.
Yeah, it's interesting also that they've got the plot on the 1982 prospective payment system, DRGs. I don't know what that's for.
So that's we have that in Australia. So DRGs are kind of like units of work. So you get paid. There's this sort of measurement of how much work output you're expected to have, and you get paid in relation to that.
Yeah, it's weird.
It's complicated.
But so what? There are other things that are on my mind. It's like the healthcare options and system obviously was very different in 1975. I don't think people were going into the NHS and asking to get breast augmentation, which is a thing that you can get if you're depressed. I don't think they were dealing with the same level of mental health issues. I know when speaking to somebody I know works in the a hospital in Bedford where I live, they say people are now treating hospital A&E like a doctor's surgery. And they've got short... I've been, because I have SVTs. You've probably heard me talk about that. And I've been... And I'm there for 4 hours, 5 hours. I have a number of blood tests, I have an ECG, and then I go home. But they said they're dealing with an insane level of this stuff.
Yes.
And so I think, obviously, part of the change has probably been the change of medical services provided.
Potentially. There's certainly more demand on resource because, we understand more about medicine. And there are more conditions to treat. And the population is getting sicker in general, as well as older in Western countries. So there's certainly more demand. But I have to say that...
Getting sicker because they're getting older? Is it an age thing? Or are we just getting sicker?
Age and things like obesity, which definitely increase your risk of other problems that require hospital services.
Okay.
And if you require a standard problem that's not related to obesity, like let's say you have a hernia repair or something, if you're obese, you're going to be in hospital longer and your complication rate for the wound that you have is higher. And so you require more hospital resources.
You might even need a bigger bed that costs more.
Potentially. We have some of that too.
You do.
So there's definitely more demand from that side of things. However, I will say that in general, things should be deflationary, right? We
Yeah, of
talk
course.
about this.
Yeah.
So as we improve our technology, we should be able to do things more cheaply. And there are plenty of examples of that. Now, I deal with a lot of bowel cancer. Even just in the last 10 years, we've gone from most bowel cancer being treated with surgery to, in certain types of bowel cancer, only half of the patients requiring surgery because we can provide outpatient treatment with medication that fixes it. So you no longer need an operation. So in general, it works both ways. As healthcare advances, we shouldn't necessarily expect everything to cost more because we could probably treat a lot of things a lot more simply with increased knowledge and technology. So I don't think the advancement of healthcare necessarily results in additional costs. What I think results in additional costs is the fact that healthcare compared to other things like food and housing and whatever you want is generally a more scarce asset. And so diluting the money supply results in quicker inflation in that asset or in that service.
Wow.
And that, to me, that is the single biggest ticket item here. It's not so much the aging population. It's not so much other aspects of inflation. It is simply that aspect of inflation.
Have you been saying to your colleagues at work, Bitcoin fixes us?
I have been.
Is it resonating?
Well, it's interesting you should say that. Yes, certainly we're in the early adoption phase of that, I would say. We do have you'll be happy to hear this, but there's an Australian Facebook group called Doctors into Bitcoin.
Love that.
That has about 2,000 something members now.
What?
Yeah, it's pretty significant. Now, there's a lot of poo coining that goes on as well.
You can say shit coining, that's all right.
Yeah, but there is a fundamental understanding in that group of people that Bitcoin does fix this element of the problem, increasingly so.
Danny, can you bring back that tweet from mine earlier? I want to say something.
Sure.
It's this just blew my mind out. I thought it was so fascinating. You know the one I mean with the chart, right? So I tweeted this out. This chart is about what young people, I think it's young people, care about, the topics that are most important to them right now.
Okay.
It's going to fascinate you, and the things they least care about. Okay, so yeah, look at what is the top issue?
Inflation, yeah, which sort of expected, isn't it?
Yeah. Now go and look at the bottom issue.
Cryptocurrency, yeah.
Yeah. So
that's interesting, isn't it?
Isn't that ironic?
Yeah.
Like the thing they're most interested in is inflation, because I think.
Yeah.
This is my point I keep making. I wrote an article recently called The Cost of Government, because I'm trying to analyze, like, why the fuck are we so fucked? Why do we keep voting for people over and over again? Why do we have one shit party and then we accept another shit party? Where's the revolution? Where's everyone saying, look, enough is enough?
Yeah.
And I did the research. Like, what do people care about most? And it basically is money-related things.
Yes.
Inflation, which is
healthcare is pretty up there too, isn't it?
Yeah, cool. Yeah.
And crime.
But look,
Yeah.
the biggest, most important issue is inflation. That is the impact on my money. Inflation is making me poorer. Second one is jobs. Because whether it's your own job or the jobs in the wider economy, that's good for the economy, and a good economy is good for you.
Yes.
Okay. The economy itself is the third thing they care about. The next thing is corruption, when money is getting stolen from them.
Yeah.
Okay.
Yeah.
So if basically the majority of things people care about are money. Okay. And I think right now we're at a time where everyone knows they're getting fucked.
Yeah.
We're getting fucked on tax, getting fucked with inflation, we're getting lied to.
Yeah.
We have a solution here, but we've done a terrible job at telling that story to people.
That's exactly right.
Terrible fucking
And I think
job.
outside of these bubbles, the vast majority of people still believe inflation is normal and necessary and is just part of life.
Well, I did.
Yeah.
2%.
Yeah, I remember being like that too. But I think, hopefully more and more people slowly understand that that is not necessarily the case. And I think this is the job of these types of discussions. I mean, hopefully a few thousand people see this. And the point is to try and educate people that the source of all the problems you're worried about in the top of the chart, one potential solution you're ignoring, and it's at the bottom of the chart.
Yes.
Now, the wording might have an effect there as well. Maybe cryptocurrency as a whole may not be the solution. So that might be an issue there as well. But
Yeah.
in general, I think the education has not made it to the mainstream yet, as far as the connection between something like healthcare, inflation, and Bitcoin. That hasn't really quite made it into the general lexicon of most people's knowledge.
Well, this is one of the reasons I changed the podcast name and the focus.
Absolutely.
Like we made 860 shows, and there's very good people out there who are going to have podcasts already, are going to create new podcasts, and they're going to do that good job. But what we're doing is every 4 years we're recruiting a bunch of people into our cult, And then we're all sitting around patting each other on the back and going, isn't Bitcoin great? Did it fix it? And like, we got to get out there.
Get out there.
Get out there and fucking tell people. And so by removing Bitcoin from the podcast title, it allows me to have this conversation. It's like, I don't know what this one would call, why the healthcare system's fucked, whatever. Healthcare inflation is killing you. Something like that. And then they're going to hear, well,
that's interesting. I care about that.
Yeah, it's a problem with the money.
Healthcare.
Yeah, I care about healthcare. And there's a problem with the money.
I'll tell you the other angle that works is when you ask, like when I ask other clinicians or patients even, and I try to get them to understand, why is it that in our society, the percentage of GDP that your government spends goes towards things that you don't necessarily agree with. So if you ask the average Australian citizen,
we just had this conversation. Well, I can't remember your name. Jock. Oh, and that's a dog. Good job. So interestingly, we were having this conversation. We had Michael Dunworth in, right?
Yes.
And so we're having a conversation, and I was like, "Look, something needs to fucking change." And there's a couple of I have like these radical ideas I'd like to be tested. Like, for example, when you have an election, it's done based on a manifesto promise.
Yes.
You have a manifesto. I'm going to do this. I'm going to do that. I'm like, fuck this. When we have an election, you put your budget in. You're going to set your tax and your spend rates, and then I want to see a fucking chart.
Yeah.
I want to see Conservatives next to Labour, next to Green, next to Lib
and you
Dems.
vote based on that.
Yeah, and I think people are smart enough to go, I'm not just going to go with the one who has the lowest tax, because actually I also see the other things they're going to do to cost the budget. They're going to, I don't know, get rid of healthcare, get rid of the NHS.
Yes.
So, I think people are smart enough, but I think you should do it, and I think they have to keep to that budget.
It would make sense.
Yeah, and if they can't keep to that budget, and they have to borrow money, so they're going to put us in debt, I think we as a country, we should get a vote on it or a new election.
Yes.
Let's direct democracy, because we've just had it now. Fucking Labour have come in, and they made all these promises on taxes, and they fucking lied to us.
Yeah.
They are changing
Same thing as last time.
Yeah, same bullshit. So anyway, I brought this up. I'm ranting away. Jock over there is like, I think on our tax forms, he said, I think he was discussing with his girlfriend that we should be able to vote where I want my taxes to go to that.
Where the money goes. Yeah. Now, that will never happen. But
because they want to buy bombs.
But you have to ask yourself the question. If you give the average U.S. taxpayer and you show them where their tax money is going, many of them would probably reallocate, say, for example, some of the defense spending towards healthcare or something. Of course, like that, right? The problem with why that will never happen is because the defense spending is part of this money printer flywheel thing they've got going on, where they can print money and have it fed back to weapons manufacturers, and there's this infinite loop. Well, it's
corruption.
But the way you have to understand the way they convince themselves of this. They think it's good for the economy or whatever it is. There are ways where they convince themselves that they're doing the right thing by the people by doing this infinite defense spending flywheel. Just as an example, healthcare doesn't work like that. If you start diverting some of that funding towards healthcare, you won't necessarily see that back in terms of buying things from companies, not necessarily. And so they have these other pressures where they're prioritizing certain spending towards areas that they believe are better for their economy at the expense of the health of their own population, just as an example.
Yeah.
And so I'm not sure you'll get a situation where the different parties will say, here's a smorgasbord of things. Which ones would you like us to pay for? Because they think they know better than you. And so I'm not sure you'll necessarily ever get that. There's also this leak, like there's the Cantillon effect leak, right? So the money starts up the top, and then there's all these rent seekers that pilfer the money. And by the time it gets to essential workers, essential services, half of it's gone, And this is the other angle that works is, I often will say to a nurse, for example, do you think it's normal that, with all due respect to, say, real estate agents, do you think it's normal that real estate agents make way more money than you in Australia?
Right.
They're not qualified. So why?
I made a film about inflation in the UK.
Yeah.
And we went to a food bank, and there was a nurse there.
Yeah.
And honestly, it made me so angry because my mum was
a nurse. Yeah.
So you saw it.
Yeah, I did.
It made me so fucking angry because
Yeah.
she is a nurse. And then she went through the COVID bullshit and dealt with all that, all the pressure they're under, she did years of, and I'm like, nurses have to train fucking hard.
Very hard.
I think possibly nursing is the most underpaid industry I can think of.
I agree with that. Nursing and, in my opinion, nursing and teachers are the two most undervalued professions because they are fundamentally important to the functioning of a society, right?
Yeah.
But they're not valued in that way.
Yeah, but at least you can take teaching home and do it yourself. You can't
probably could. You probably do it online. That's fair enough.
You don't want me on like what's that fucking website looking it up and treat myself. But nursing. I mean, how many years do nurses spend in college?
4 to 5.
4 to 5, and they work a high-pressured frontline job,
Hard work.
shift work as well,
Correct.
on their feet.
Yeah.
And she has to go to a food bank.
Amazing.
That's a shame in our country.
I agree with that. And that's the case in most developed countries. It's not just your country. It's most countries.
I don't know why someone would want to become a nurse.
Yes. Well, because they're good people, generally.
yeah,
they're
of course.
altruistic. And I think, we need to value that more just in general in our society.
Do you think there's an imbalance between how nurses and doctors are both valued and compensated? Because I know, look, doctors are have to be super smart, and
Yeah.
they do 7 years, and
Yeah.
they essentially, the junior doctors I know start on lower pay, but most doctors will make good money at some
Correct.
point.
Yeah.
But there seems to be an imbalance between how both are valued.
Yeah, I mean, it depends on how you see. Like, I'm what's called a consultant, right? So that's when you finish training
Yeah, yeah.
and you become a surgeon. It depends on whether you think I'm worth more than, say, the CEO of an accountancy firm. Am I worth more than that person?
If you save my life, yeah.
Right. So it depends on that. The level of responsibility is the other thing you get paid for. So, if a patient dies on the ward, generally speaking, the buck stops with the consultant, whether that's
Right.
a physician or a surgeon. But yes, in general, surgeons and doctors make a lot of money. We are relatively well off compared to the rest of the population, particularly in Australia.
Yeah.
I guess the question is it, are we worth it or not? That's
Yeah,
a
but
very different question.
I'm not even questioning that. I'm thinking it's that we just undervalue and underpay nurses.
That may well be true, but I think the main reason for that is there's probably multiple nurses for each consultant.
Yeah.
And as we pointed out before, the healthcare system is just underfunded, and it's been chronically underfunded every year. If the healthcare system was compensated by tax money at the rate of 10 to 20% a year, then relatively speaking, nurses' salaries would be significantly higher than they are now. And they should be significantly higher than they are now. I don't think necessarily our salaries need to be much higher. I think we are valued simply because of the amount of responsibility that we have to take on, not so much the hours. It's more like the buck stops with you and you have to make all the decisions, positive or negative, and live with those decisions. And to get to the point where you can do that is very difficult, in terms of time spent and hours worked and just stress levels. It's not easy becoming a doctor. It's actually very difficult in terms of stress levels. And I think our compensation, relatively speaking, comes because of that, as opposed to the number of hours worked.
Very important that you don't lose this, okay? This is your inheritance through Bitcoin.
Let Bitcoin rip. Don't rip up your Bitcoin. Set up inheritance with Casa.
So do you think a return to a sound money standard does fix a lot of these problems?
Well, it fixes, yes, in multiple ways. So one, we talked about the time preference issue. So I think a healthier society will use less healthcare resources. I think understanding healthcare price inflation better than we do now will go a long way towards improving the levels of funding that we get, which we're currently not getting. I think reducing the amount of leak in the system, so reducing the Cantillon effect where a lot of the money goes towards places that are just getting preferential benefit just because of their proximity to the money printer. And that includes things like finance types, stockbrokers, real estate agents, bankers. A lot of that money is going in places where it probably shouldn't go. And I think that would help. And then finally, there's this broader issue, which you sometimes touch on as well, which is the global health issue. My obligation as a medical person is not just to the people in my hospital. My obligation is towards the health of society in general, including in countries where I don't work.
Yeah.
And there's absolutely no question. I mean, you've gone to Argentina and Lebanon. You've seen what hyperinflation does to society.
It's devastating.
And it devastates their healthcare systems. Yeah. I'm Palestinian. I'm not as hardline as some of the other people you may have had on your show, but there's no question that there are fiat-related causes of extreme global health disasters. What's happening in Gaza and South Lebanon right now is a global health disaster, regardless of your politics and your views.
Well, I call it a genocide.
Yeah, I mean, but the people are still alive. The people are still alive. I mean, the amount of healthcare resource that's going to need to be used over the next few decades to sort out that mess is astronomical.
Yeah. So interestingly on that one, so obviously Israel has blown up many hospitals because they believe Hamas or whatever. There's a severe lack of access, obviously, you'll be aware, to
Yes.
medicines, even like fucking painkillers.
I mean, some of my colleagues have gone there to just as
Horrific, right?
aid workers. Yeah, and the stories they bring back are horrible. You know, like unsedated amputations in kids
Yeah.
and all this sort of stuff. It's disastrous.
But-
And it is a global health impact. You know, a lot of the global health resource that we donate to from other countries, some of that is going to have to go there. And
But it's the trauma now that they're going to have to deal with.
decades.
afterwards. Decades.
It will be
trauma.
decades of healthcare. Like I said, forget about the politics of the situation. Just purely from a medical perspective, healthcare perspective, there's going to.
I wonder how much Israel have spent on that war. I'm going to make one
It's
of my.
measured. It's measured. It's obviously a lot.
I wonder if
Billions.
they put that money into building hospitals in Gaza
Yeah, I mean,
and schools.
yeah, I mean, yes, exactly. I guess the question is, without going into too much politics, that place, being originally from there and hearing the stories, that place will always be a hotbed. It's been a hotbed for thousands of years. It's not a. While the most recent issues, I guess, might have started in 1948, the reality is that throughout the ages, going back to BC even, that place has always been a hotbed. Whatever the empire of the day happens to be, they want to control that piece of land. And the question is, why is that? And it's a pretty simple explanation. Africa basically hangs off Asia by this tiny strip of dirt, right? And so if whichever empire you happen to be, whether before the current empire, the British were there, before there was the Romans and the Ottomans and so on and so forth. And at every one of those points, a population in that region was being persecuted with the goal of controlling the land, right? And what's happening now, and the reason it's a bit more extreme now in that part of the world at least, is because, money's cheap and wars are cheap. And it's people are making a lot of money off generating this flywheel of, the military industrial complex. So, hashtag make war expensive again to try and at least reduce the incentive to continue these perpetual wars.
It's so funny. You can't help but once you've seen into the matrix of the.
You see everything with that angle.
Yeah, you see it all, and you just think,
Yeah. One thing we have to watch out for is this whole extremism angle. I consider myself a Bitcoin maximalist, but I am very cautious about all forms of extremism because what tends to happen and what I've observed is like extremism begets more extremism. And all that changes is the population being persecuted. So just as an example, the solution to Nazism and the horrors of the Holocaust is not Zionism. And furthermore, the solution to Zionism is not Islamism, right? The solution to extremism is not extremism,
yeah.
okay? Rather than extremism in the opposite direction. So, if we go forward here, hopefully one of the messages we can give out as medical people and as other people, good people, is if you find yourself in a position where you're inflicting harm on innocents, regardless of your ideology, you are now the problem, regardless of your ideology. So just realize that and stop doing it.
Yeah, man. Wow. I'm just trying to think. I think it's just Tottenham fans I put. So okay. So back to the healthcare system.
Yeah.
So okay. Obviously, we understand, and I agree with you that healthcare inflation is a problem. But if you were going to design a healthcare system now, you have full control. What would you do? What are the big changes? Where do you see stupidity? Like in the UK, you get free doctor's appointments, and if you don't turn up, so be it. And they have something like 12 million a year. Whereas in Ireland, you pay £50 for whatever appointment. They have less of an issue there.
Yes, I've heard you talk about this before. There is merit in having some sort of token payment to stop abuse of the system, right? But bigger ticket item, I would design a system where the private and public sectors are complementary and competing against each other.
Okay.
To keep each other honest. So you don't want too much bloat in the public sector, and you don't want too much sort of cruelty or hard-linedness in the private sector, like the example you gave of the drugs. What you want is two systems that are roughly equal in size, that are able to keep each other in check and help each other out as required. So for example, you have a global pandemic, like we had everywhere, you can flex beds into the private sector, which I think helped Australia a lot, for example. I'm not sure if many people are aware of this, but private hospital beds here were extremely useful to try and keep the ship moving during COVID.
Do private hospitals have a beds issue? And I know that sounds like a simple question, but planning beds is difficult.
Yes.
But do they have their own beds issue, or is it just because it's purely private, they always have enough beds?
Some do, and in this part of the world where the private sector is large and partially government funded, there are certain bed pressures in certain areas, but much less than the public sector, because the overall amount of work is less, and because it is user pays, and so they're relatively well funded compared to the work that they do.
So if you had a fully private system, do you think there would be any bed shortage, or do you think a fully free market will always have enough beds?
Well, does America have massive bed shortages?
I don't know, but we also know
Not
that
really.
it doesn't.
Not really, but a lot of the hospitals, you can't get in because you don't have the right level of insurance. So the gatekeeper is the insurance, not the number of beds.
But interestingly, I had one of my SVT episodes in where were we? Miami. Danny walked me over. The experience was similar to the UK. It took about the same amount of time to be seen. The whole experience was 4 hours? About the same, 4 or 5 hours. They prescribed me a couple of tablets I had to take after, which doesn't happen in the UK. And they run more tests in the US. And I asked them why. And they said, in case there is an incident and we're exposed to litigation. And then I got a bill at the end. But it was still just as inefficient.
Yeah, I mean, were you? I've heard you talk about this a bit before, but were you aware of the level of insurance you had?
I didn't have any.
There you go. So you had a different experience than someone else in that part of the world.
Okay.
The system in America works really well for the wealthy who have enough level of cover to access the best healthcare in the world.
There's great hospitals for rich people.
Fantastic. I mean, the hospital I worked in there was literally the best hospital I've ever been in. It was unbelievable. The amount of service I could provide for my patients was like a breath of fresh air. There was literally no resource constraint
but
at all.
That was like with my microdiscotomy, right? Because I've had private healthcare, I want to say now for 20 years.
Yeah.
And
in the UK.
In the UK.
Yeah.
And it's gradually getting more expensive.
Yes.
When I first got it, I think it was about £120 for me and the kids a month. We're at least double that now.
Yeah.
I've had my microdiscotomy. My son has shin splints. We've been looked after.
Mm-hmm. Well, what's the insurance rate of the UK population? It's only about...
I reckon very, very low.
It's about 20%.
And it's the last thing I'd get rid of. I would get rid of cable TV before I get rid of this. It's the last thing I'd get rid of. But the point is I don't know what the waiting list is for a microdiscotomy.
In public.
I have no idea. And also, our hospitals, they're not great. They're shared wards. They're people are overworked. The food in the kitchens are crap. They just feel crap.
Yeah.
My microdiscotomy was private. I got it booked within 3 days.
Yes.
I had a private room for myself.
Mm-hmm.
I had a nurse looking after like 2 people. I was one of them.
Mm-hmm.
The care was unbelievable.
Yeah.
It was a proper service.
Yeah, I mean, the private sector in the UK is great. However, there's only about 20% of the population that is insured. And so
is it that high in the UK?
It's about 20%.
Really?
I'd say. Yeah.
I'm surprised it's that high.
Yeah, it's about 20%. In New Zealand, it's about 30%. And in this part of the world, it's about 50, high 40s, low 50% in Australia. And so what you want, I think, if you had your way, is to have a more balanced system where it's not so much leaning in any one direction.
Can you get it to a point? So what you're saying is comparable services. Mm-hmm. Are you basically saying, look, one of the things we have to accept is that people with a bit more money, they get to get they get better medical treatment and they get to drive nicer cars and live in bigger houses. It's the same.
Yeah.
But if we get the balance right, we can raise everybody else's healthcare.
Absolutely. If you get the balance right in the design of the healthcare funding, which a lot of places have and a lot of places have not, then you get better outcomes for everyone, including the wealthy and including the not so wealthy, because the systems complement each other. So in this part of the world, for example, a lot of us are incentivized to get health insurance because if we don't, we are taxed taxed more than the cost of the health insurance.
So explain that to me. Sorry.
So the way the healthcare system works in Australia, so there's private and public.
Yeah.
Health insurance, there's multiple providers all competing for your business, like many.
Yeah.
What the government says is we are going to tax you, what's called a Medicare levy, if you don't get health insurance above a certain salary. So if you've got a certain income per year, if you don't get yourself health insurance, we're going to add a bit of tax to incentivize you to get health insurance. So no, but generally speaking, if your income is above about 200,000 to 300,000 Australian dollars a year, it makes no sense to not be insured because you're paying more in tax than the price of the insurance that you get.
Yeah, but that's a high salary.
High salary.
Yeah.
Yeah.
Well, what level salary is it mandated?
It's not mandated.
Okay.
But it's incentivized through
Where's the-
taxation.
Okay. How expensive is?
It's I would say moderately expensive. It's cheaper than New Zealand because of the size of the system.
Yeah.
But it's probably more expensive than some other places.
Just say,
as an example,
a young man,
myself
yeah.
and my family. So I've got 2 young kids.
Yeah.
Myself and my wife. We're all very healthy. We pay about, I think, something like $400 a month for high, top quality hospital cover.
Hold on, but that's not expensive. That's £200 a month.
It's not that much.
Yeah, I'm paying £250 now for me and my 2 kids.
Correct.
And we have the highest care that Vitality provide, which includes the best cancer cover.
Yes.
You're immediately in to see a consultant within like 24 hours and immediately into care, right? £250 a month. That started, like you say, it started about 120, 130 when I first got it. But we have, and by the way, we use the system.
Yeah.
But I don't think it's a lot, but I don't think it's a huge amount of money.
It's not a huge amount of money.
I think a
Especially if
lot of
you're
people
middle to upper income
Yeah.
brackets. It's not a huge amount of money,
This-
but it takes a lot of pressure off the public sector. A lot of pressure off the public sector, which in New Zealand, for example, is not the case. So in New Zealand, the public sector is a bit more stretched because only 30% of the population are insured, and there are no real incentives to be insured.
It's one of those things you have to like experience it though. Once, because I got given it for my first time,
Right.
and then used it,
Yes.
and then I was like, oh,
Yeah.
this is what I'm paying for.
Yes.
Okay.
And there is a bit of a cultural barrier in the UK as well because the NHS is so valued that people don't necessarily see private health cover as being, something that important. Because
But there's a shift coming with these. You've definitely heard me talk about the private
Yes.
doctors, the
Yes.
private GPs. Every single person, it's an easy way in because it's £50 for an appointment.
Right.
And everyone I know, they're complaining about the GP. I'm like, just go to the medic centre. It's £50.
Yeah.
They're like, fucking hell, I got it in the same day.
Yeah.
And I think that's starting to kind of condition people to this idea. Actually, it might be worth paying for my medical
Yeah, and I
stuff.
think it's out there in the lexicon of our world that certain healthcare systems are performing better than others, right? So if you ask the average Australian doctor, they'll tell you that they're sort of aware of which healthcare systems perform better than others. We get a lot of NHS doctors that come here, right? And they tell us what they're experiencing there. We don't get any US doctors that come here, but a lot of us go to the US and work there for a period of time. So we get a chance to see how things work in different places. And I can honestly say a balanced public and private sector gives you the best outcomes for everyone, including those that would consider healthcare a luxury.
At Ledden, we built the best Bitcoin-backed loan platform in the world. Proven, trusted, growing. Ledden's proven track record speaks for itself. Visit ledden.io/Mr. Obnoxious to get started. Ledden, there is no second best. Ledden is not regulated in the United Kingdom. Any credit products or virtual asset services provided by Ledden are not subject to UK regulatory protections. Please consider the risks associated with virtual assets and consult a financial advisor before making any decisions.
Well, so what would you say to the libertarians? Say absolutely not. The entire thing should be a free market.
I think that's a somewhat of an extreme view when it comes to healthcare. I think when it comes to something like freedom of speech, they may have more of a point. But when it comes to something like healthcare, where, how does that determine the healthcare of a 5-year-old? Well, that's my question to them. If you're 5 and you have no parents, what happens? You have to get insurance? So at some point, you have to accept social services at some point, even if it's just for children.
Yeah, see, that's
Yeah.
but the whole.
Yeah.
So this is one of the areas because I'm becoming quite libertarian in some of my
understand
views.
that, yeah.
I want smaller government. I want taxation, but I keep running into things like hurdles I can't get over them. One of them is social services for kids. I cannot see how that can be provided privately. Maybe charities, but there's such a demand.
Yes.
I just cannot get over that hurdle. And I've read the literature, I've read the arguments.
Yeah.
I can't get over that one.
And I agree with the idea of, as little tax and as little government as possible. But the idea of having, total free market dynamics, I think will jeopardize the weakest in society. And I think that is unacceptable to me. So at some point, most humans will realize that there are a percentage of our society that we must look after. And we must look after them through some sort of shared collective agreement through government is probably the best way to do it. Now, the government does have a habit, like we talked about with the administrative side of healthcare, of getting bloated.
Yeah.
And so there should be checks and balances. And that's why I say I don't agree with a 100% socialized healthcare system. Because when you do that, it becomes grossly inefficient. And it becomes unacceptable even for the average person. And so what you do need is this competing idea between libertarianism, free markets, and socialism and the government. These ideas are complementary and competitive. And I think if you go too far in any one direction, and I can only really speak for healthcare, outcomes get worse. That's just a fact. And I'm not sure why people would find that hard to accept.
Yeah, I guess if you encourage more people into having private healthcare, that would reduce the bloat of the NHS and drive the efficiency
100%.
that we need. So it's a good
Yes.
balance. But when you're traveling, so here or when you're in the US, is the NHS something people look at, they think about? Is it discussed widely? And
Yes.
how's it perceived?
That's a very good question. Because we're sort of an Anglo-Saxon country, I mean, the king was just around here, walking around. I don't know if you know that.
He wasn't welcome, was he?
No, well, by a small percentage of the population.
No, there was that one,
The Lydia Thorpe.
Yeah, she was yelling at him.
She was, I think, I think that's a little bit too far. Interestingly, I've got UK, New Zealand, and Australian citizenship. So the king applies to all three of my citizenships. I'm not a fan of an idea of having a group of people that are unelected but somehow have special status, but that's because of my bias. I understand the history of it, but
fuck
so
the
I'm
king.
not a, so I'm
Probably go to
more
jail.
of a Republican.
Can I get arrested for saying fuck the king? Sure.
Hopefully not. Maybe in the UK.
I don't know, it
not
might throw
here.
me in jail.
Yeah. So here we see the NHS as a laudable concept, but that has somewhat failed in practice because of the bloat in the public sector. That's how we view it here.
Okay.
And that's because we see the doctors escaping and the nurses escaping, and they tell us why they're escaping. My salary is roughly, I don't know, something like twice my counterpart in the public sector in the NHS. Why is that?
Wow.
I don't provide any more service.
So that's it. So they're leaving there to come here, and then we're taking the ones from
Yes.
like Lithuania
Correct.
or wherever.
That is exactly what's
Okay.
happening, not at a massive scale, but that is what's happening in general. And that's the general perception, that the system has gotten too bloated and inefficient because it's too public sector heavy.
Right.
That's the. I'll give you another example. One of my colleagues just came back from a very good fellowship in the UK, and he tells me that a lot of the days the operating list, the theater, doesn't start till like 10 a.m., which is strange to us here because we start at 8 a.m. here. And the reason for that is bureaucratic. So like the doctors are there willing to work, but there's all these bloaty things that happen around the administrative side that means that things have slowed down. So it's hard to get the patient into theater and anesthetized for you to actually do your operation. Things like that, inefficiencies. And that's our perception on this side of the world. The concept, however, is laudable. And not only that, we appreciate that was what started it all. That's the OG from our perspective. That's what led to the healthcare system here, because the British brought it here. Similar in New Zealand. So we understand the history of it. We understand the laudable idea behind it and the principles of it, and we respect those greatly. So
But time to modernize.
Well, it's time to take a more balanced approach
Yeah.
where you have two competing sectors, a little bit more balanced in that way.
See, these come under that kind of public-private partnerships
Right.
kind of area, and there's a real distrust of those. And I
Understandable.
tell you why there's a distrust. I mean, you probably know, but like, there's a couple of reasons. Firstly, it tends to be their buddies, their friends get contracts. It's just out and out corruption.
Correct.
Well, no, it's not out and out corruption. It's just coincidentally their mates get the jobs.
I don't necessarily think you have to have a hospital that's both public and private at the same time. What I'm saying is two separate sectors, one public, one private.
Well, we kind of have that. Though. We don't actually.
Yeah.
We don't have many fully private hospitals.
No.
I don't think. I don't know if we do actually. What
The
we
system's a bit smaller. So the private
Yeah.
hospitals are a bit smaller, and the amount of
have.
work.
They're quite specialist as well.
Correct. And the amount of work that's being done is, in terms of numbers, is a bit less. So here, about half the surgery is done in private and half is done in public. In the
Right.
NHS, it's a much heavier skew towards public.
I guess all I think of hospitals are these big buildings that do everything.
Right.
Whereas all my private treatments have been specialist.
Yeah, but that's because the private sector in the UK is smaller than here as a percentage of the population. So here you will have a very large, like Melbourne and Sydney have very big private hospitals that do everything. They have
Right,
an
okay.
emergency department, they do massive surgery. It's a fully fledged big hospital that is for insured patients and that is privately funded.
See, what you don't, I guess what you want is a private system that's completely separate from government.
Yeah, yes and no.
But if you take government money and
Yes.
put it into private operations,
Yeah.
they look at ways to squeeze the incentives, and they look at the ways to benefit themselves. And it's not truly free market.
Not true free market, but you do need, in healthcare, you do need some level of regulation because of the issues we talked about before.
Yeah.
So you can't necessarily have a completely standalone private sector that has no input and no regulation, because sometimes what happens there is, especially if there's a particular need in a small niche area, the prices become exorbitant and unfair. So yes, there should be free market surgery, free market medicine, but there needs to be a certain level of oversight as to how that is conducted. And whether that's done by government or another entity, you can debate, but I don't think you can have it completely rogue, because weird stuff can happen when you do that with healthcare.
Are there any other big ticket items you would change?
I think the balance of where the taxpayer money goes needs to change, and I think most citizens would agree with that. And so I think the mismatch between citizenry's views and where the money actually goes needs to be rejigged, and we discussed that. I think there's a lot of waste as well within healthcare systems. I give this example in one of my other talks. I did a TEDx talk a while back.
Oh, cool.
Where I mentioned that, for example, something as simple as wound dressings. Like when we do surgery, we get this choice of what wound dressing we want to put on. Now, if you look at it from a scientific perspective, and I do have a scientific side to my life because I do some research with the uni, wound dressings do nothing. They literally do nothing apart from keep the stuff off your clothes, so there's this practical element to it, but they don't help the wound. That's pretty well established.
Hold on, they don't protect the wound from not getting infected?
Not really, So the determinants of wound infection have nothing to do with the type of dressing you choose. It's irrelevant, okay? And that's well established in the scientific literature, that the wound dressing does nothing. The rates of wound infections are determined by the type of surgery you've had, if you've had contaminated surgery versus clean surgery, whether you're a smoker or not, whether you're obese or not, whether you're diabetic or not. So all these factors related to wound healing and contamination. The topical stuff on the wound is irrelevant, and that's well established. Now, there are very expensive dressings, and a lot of us use them because we don't know any better and because we like the look of them, or we think somehow there's some hocus-pocusy reason why it makes a difference. And I think things like that contribute a lot to the healthcare spending, but you don't actually get anything for your money.
And there's probably tens of thousands of examples like that all through the system.
All through the system, which could be rationalized. But what's required for that is less managerial class and more medical class that is involved in management, which is difficult to achieve. So you need someone like me, for example, or one of my colleagues to want to look at this and influence the trajectory that the hospital is going at, as opposed to getting a non-medical manager to decide what dressings should we buy for this hospital.
Is there a bit of a them and us relationship in hospitals?
Absolutely, because yes, there is. And there's a weird power dynamic where someone's paying your salary, but you know more about the patients. So you control what happens with the patients, right? You have the responsibility for the patients, but someone else is your employer. And that creates a very strange dynamic in the hospital where the person taking most of the responsibility for the delivery of this essential service is not necessarily the same person that's in charge of things like funding. Separate. And so there definitely is that. Now, occasionally you'll get a fantastic manager who is sensitive and understands all these issues and works with you really well. But that is the exception rather than the rule in most of my experience.
But you can't have very bad surgeons, because if you're very, what's the kind of the equivalent here if like medical malpractice?
Yeah, so we have that here. So there's two avenues in this country. There's the lawsuit avenue, and then there's the medical complaints avenue.
Yeah.
Somewhere like New Zealand does not have a lawsuit avenue. They just have a medical complaints avenue, for example, because they have this thing called a no-fault system there. So if you make a mistake or you cause harm, and that includes things like car accidents and all sorts of things, they have this thing called a no-fault system where the government takes you on and gives you whatever you need as the recipient of the whatever bad thing happened as part of an accident. And that includes things like surgery and medicine. So in other words, patients don't sue doctors.
But could you get struck off?
You can, through something called the Health and Disability Commission, which assesses your performance and go, you're not fit to practice.
But it's very rare, right?
Rare.
Yeah. Because
it's rare.
Because it's important. You've got to have people of the right standard, the highest standard, quality, experience. Yeah.
Well, by the time you get spat out the other end through all the training, usually you're 99% of the time you are safe and competent. Otherwise, you don't make it.
I guess where I'm going is this: should we be doing the same with people within the managerial class of this.
Ideally, but how do you measure performance? And that's one of the issues is, patient outcomes are not directly related to who the manager is. They're directly related to who the medical team is and this nursing team is. So how do you measure performance? The only way they measure performance is budget. Am I in the red or am I in the black? So, and that's not a good measurement of performance in this field, right? So it's a difficult problem.
Yeah, it just feels like it's such an important relationship. Like, it's like right on my football club. Me and my manager have to have a really, really close relationship, but we have complete separation of duties. He's on the pitch, I'm off the pitch, and we've kind of aligned in the goal. But how we get there, there's conflicts, and we have to have a very good relationship to figure those out. I'm guessing you really need a good relationship with these people to figure.
You do, and it's hard to get because you have some such different worlds. And again, the power dynamic is very strange because one group controls the purse, and the other group is directly responsible for the outcome.
Could consultants become?
Yes,
and
but it's pretty rare. It does happen, but it's actually quite difficult, and it takes a certain kind of person to be able to cross both boundaries. So, for example, I like crossing the boundary between medicine and research and science.
Yeah,
I don't like crossing the boundary between medicine and administration because I don't see myself as a good administrator. The type of surgeon that's a good administrator is a particularly unique type of individual typically, and it's actually very difficult to be good at both because they're such different worlds, So yeah, it's that part of it I don't have a good answer for, I should tell you. However, I think if you design a healthy system, a lot of these things take care of themselves, if you know what I mean. So if you have a healthy competitive system between public and private sectors, what happens is the public sector is held to account for general performance, and the private sector is the same. And so these counterbalancing forces generally result in a healthier managerial class, I would say. As to what, a better answer than that, I cannot give you, I'm afraid. It's a difficult problem.
Yes, it's fascinating. Yeah. Any other big ticket items? Because these are all fascinating.
Not really. I mean, I think, the things we talked about, the global health element, having a balanced sector, reprioritizing what does the citizenry actually want? How much of their tax money do they want going to healthcare and education specifically versus other things? And understanding that we are going backwards, and we need to be honest about that, in terms of number of beds and capacity.
But bro, we're going backwards with everything.
That's also
money.
true. That's also true.
I feel like everything is going backwards.
Yeah, that may be the case. But we have potentially have some solutions on the horizon. So there's reason to be slightly optimistic, I would say.
Is there anything I've not asked you wish I had?
That's a good question. Not really. I think we've covered a lot of ground, and I'm pretty happy about what we talked about today. So thanks again for
appreciate it, man. Honestly, it's one of those ones where I'm like, I need to go away and do some more thinking and then cover this again because I'm really interested in it as a subject. I'm interested in it because it challenges that libertarian world that I've been running headstrong into.
Well, you've had a lot of conflict about that, haven't you? Like internally, forget about the external views, but you've gone from sort of being a bit more socialist to a bit more libertarian. But I can see that both worlds don't quite sit right. You're not sure where it belongs.
I think I've figured it out. And so what it is no ideology is perfect, right?
Yes.
And one of the things we can't get away from is that I think government is an emergent system.
Mm-hmm.
If you take 50 people, you stick one on an island, you wait a year and you record it, they're going to create a government on there at some point to make decisions. It's just this emergent way of making decisions, but it can become corrupted. Luckily, at some point we got this thing called democracy, which was meant to give us the ability to vote on an outcome. Obviously, governments become bloated. I actually think the solution is with the libertarians, but it isn't libertarianism itself.
Not extreme libertarianism.
No, it's libertarian influence in government.
Yes.
I think what we need to do is have an educated population understand the basics of economics, understand, the basics of economics, how systems work, and be able to think critically. But I think the libertarians who think there's no government, they're unhelpful because basically you've got an idea that can never exist. It's never going to happen.
Any extreme view typically is wrong. And I'll tell you another analogy.
Can I just say, I was going to say, but the libertarians hold the keys. If the libertarians go into government, go into any party and go with a strong voice, all they have to shout for is, we have left, right, no. What we need is big, small, big, small. Rein it in.
Correct. Balance.
And I think that comes from a strong, educated, articulate group of libertarians get into politics.
No question. I mean, I've lived in democracies and non-democracies. I lived in Dubai for a very long time. I grew up there. And I can tell you that the reason democracy works is not for, in my view, is not because of the reason people think it works. People think it works because it's this noble cause. But the way I see it working better than other systems is, I'll give you an analogy of a bowling alley. You know, if you can hit the pins as a strike every time, that's great. But if you can't, and if the issue is too complex that you'll never be able to get it right, then putting those guards on the side where you bounce around between two thoughts, in this case right and left, or authoritarianism and libertarianism, that's how democracy generally works. And if you look at most democracies, they swing between right and left and between libertarian and authoritarianism with time. And they end up in this somewhere in this, sort of, it's
messy
not clean.
middle.
It's messy middle. And the messy middle is how this works, because at the end of the day, humans are in the messy middle. That's how we work. And so having any thought where you think that one particular system, whether it's public healthcare, socialized medicine, or ultra-capitalist private healthcare, or whatever system you're thinking about, if you go too far in one direction, you will pay the price for that in other ways. It's that simple. And so I think if we can get to a point where we accept the messy middle and understand that a healthy balance between different ideologies probably gives the best outcome for the most people, that would be the true revolution in my view. Rather than keep fighting over, are you on this side or that side? And there's no middle in between that works.
That's a profound ending, man.
Yeah.
Give me a lot to think about.
Yeah,
I really appreciate you coming on and doing this,
I'm really
man.
glad to be here. Thank you so much for giving me a platform, and for, it's a pleasure to be here. I've watched your show for years, so
Thank you, man.
I can't believe I'm on the other side of the table.
Well, listen, it's all earned. Okay, well, we should go and get McDonald's and get drunk.
Sounds good. Good for bowel health.
Smoke some crack. All right, thank
Sounds
you.
good. Thanks
See
a
you
lot.
later.
Cheers. Thank
you, everybody.
Cheers. Thank you.